Good evening, everybody. We'll give everyone just a moment to make their way in before we get started. How are you, Dr. Murray?
I'm doing great. Hopefully everyone is staying warm tonight, and I'm really excited about this presentation.
We're very excited. Myopia management gets a great turnout. And we actually have a ton of people already in here. So I'm going to get started. Welcome to tonight's Wu University event, Growing Your Myopia Patient Base with Dr. Marie Homa Palladino. Thank you to Cooper Vision for exhibiting at tonight's event. I'm your host, Dr. Jennifer Stewart. So just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display the QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure to ask questions using the Zoom on-screen floating panels. If you're on a mobile device, this is where you can find the Q&A and chat. So it's my great pleasure to introduce tonight's speaker. Dr. Marie Homa Palladino is a director of the Medical Optometry America Myopia Management Center of Excellence. With more than 30 years of experience in medical eye care and over a decade in myopia management, she is now dedicated exclusively to myopia management. In addition to treating patients, she's committed to advancing the field of myopia management. She frequently lectures at local and national meetings and lists on the board of directors for the American Academy of Orthokeratology and Myopia Control, serving as secretary of the board, member of the executive committee, and liaison for MJH Life Sciences. She's one of 60 doctors selected in the U.S. to be a change agent for the AOA Cooper Vision Myopia Collective. This is a new initiative aimed at rallying the profession of optometry and its allies to interrupt the status quo and realize a new standard of care for children with myopia. She's a past president of the Chester, Delaware County Optometric Society and an active member of the Pennsylvania Optometric Association. She graduated from the Pennsylvania College of Optometry and was a solo practitioner for half her career, concentrating on specialty contact lens, pre and post-op cataract, and refractive surgery care. Welcome, and we're happy to have you.
Thank you. Okay, so I'm just gonna share my screen here. Okay. Thank you all for coming on tonight, and I'm very excited to talk about something near and dear to my heart, myopia management. Tonight's presentation is going to be about growing your myopia patient base. And this is not really, it's not a marketing webinar. It is more a communication webinar to really get you to know your patients and to communicate better with them, identify your patients who are myopic, and really to serve this growing population of kids who really need our help. So I'm not going to be talking about Google ads or SEOs or anything like that. That's not what this is about. It's more about knowing who to look for, identify, and why we're doing all of this. Here are my disclosures. They've all been mitigated. Okay. So we all know about myopia. This is a chronic disease. You know, the eye is elongating. It causes symptoms of blurry vision. And the problem is that the eye is growing too long, too fast, which weakens the back of the eye. So then you're at higher risk for eye diseases in the future. So traditionally, you know, we correct the vision at the foveal plane, but with myopia control, what we're trying to do is really bring that image inside the scleral shell. So a lot of our treatments are targeted, our optical treatments are targeted towards that. Um, So why is this such a big problem? Well, globally, more children are getting more myopic at a faster rate and resulting in higher myopia overall. Um, Myopia long term has detrimental effects into adulthood, and it's amazing the statistics at this point. 23% of the world's population was myopic in 2001. About 50% of North America will be myopic by 2030, and that's only 5 years away. By 2050, about 53% of the population of the entire world, it's about 5 billion people, are going to be myopic. And of those, 10% are actually going to have high myopia, degenerative myopia. So by 2050, myopic degeneration will become the #1 cause of blindness and visual impairment in the world. This is really unbelievable. And this is why we really, really need to address this now. The problem not only comes in that, that glasses get too strong, or you need thicker lenses or contact lenses. The problem comes in with the retina. And as you can see by this chart, increasing amounts of myopia cause an increase in retinal detachments, myopic maculopathy, cataracts, glaucoma. So we really want to try and target our kids and our teenagers to actually stay under 3 diopters of myopia by the time they graduate from high school. So it's not just solely the refractive error. It also is axial length. So as you can see here, the prevalence of visual impairment increased dramatically as you increase axial length. So one of the things you really need to be aware of is if you have a low myope and they have really flat Ks, chances are they have a long axial length. And with that long axial length, they're going to be at higher risk for retinal changes, in the future. So that's something to just be aware of also. I'm a big proponent of axial length, measuring axial length. I know not everyone has that measurement, but you can take a look at refraction and look at your Ks, and you can kind of determine where a child is from that. Okay, so also each diopter of myopia increase, it increases the prevalence of cataracts, open angle glaucoma, retinal detachments, myopic macular degeneration. Every single diopter matters. So you think like, oh, well, it's once 1 diopter, it's no big deal, right? But it is a big deal. And actually slowing it down, it makes a big difference too. So by slowing myopia progression, just 1 diopter reduces your risk of all of those things. Myopic maculopathy by 40%, glaucoma and visual impairment by 20%. So this is really, really important, and it's something that can't be overlooked. We really need to not take a let's wait and look and wait and see kind of approach. Once we get over 6 diopters or 26 millimeters, this is really considered a degenerative or pathologic myopia. There's a classification of that type of degenerative myopia. And we want to avoid this. This is what we want to avoid. We've all seen it. We've all seen it in the back of the eyes, and this is very preventable. Okay, so how do we identify these patients? Well, you need to look at a number of factors here. Ethnicity, parents, the lifestyle of the child, their refractive status, and their binocular vision status. So if you have one myopic parent who is one parent who is myopic, there's a 3 times greater risk for the child to be myopic. If both parents are, then it's a 6 times greater risk for myopia onset. Also, East Asians are much more at higher risk for myopia. And also looking at their visual environment. So you need to take a little bit of a different history for kids, find out how long they are actually spending outdoors, and what their near work is like. So less than 2 hours per day of outdoor time puts a child at higher risk. More than 3 hours of near work puts them at higher risk. And also being too close, like closer than 20 centimeters, it actually puts them at higher risk. And time-wise too, if they're on any kind of near tasks, and it doesn't matter if it's actually screens or if it's actually it's written on paper or a Kindle. Mom today said, "Oh, well, my daughter, she reads on a Kindle for a couple hours." And I was like, well, that kind of counts too. So more than 40, 45 minutes, that actually will put them at more risk for myopia onset. We need to take a look at their binocular vision status. So we know that children who have esophoria, often accompanied with high ACA, intermittent exotropia, and high lag of accommodation, they all are at more risk for myopia onset. And the number one risk for myopia onset is a low hyperopic reserve or more myopia than the normal age. So this is actually a chart that you should memorize or have just sitting next to your computer. This is something that the CLEAR study has shown us in North American population. The refractive status of a child at 6 years old they should have a 75 point, no, sorry, plus 0.75 diopters of hyperopic reserve. And then, an 11-year-old actually should be plano. They actually shouldn't be myopic. So that is North American children. There was a study that was done in China just last year, and those results were published where the Chinese children actually you need to look at a different level of hyperopic reserve. So a 6-year-old is a +2, would have to need a +2 hyperopic reserve in order for them not to be myopic. The numbers are really incredible in the East Asian countries. So this is something that's a super important slide for you to look at, because this is the number one way that you're going to identify these kids. Okay, so we talked about onset, and what about progression? It's basically the same thing as onset. Family history, ethnicity, visual environment, binocular vision, refractive error. The other part of progression is actually if they are age 9 or younger. And we know if they're myopic by age 7, they will progress at least 1 diopter per year until age 11 or 12. And you think, oh, that's just a few years. But if a child is 7 years old and they progress until they are 11, that's already a -4. So we're just really off target here. So the younger the child is, the more quickly they are going to progress. And you have to actually be more aggressive with younger children. So what do we do with these children who are who have no myopia or they're pre-myopic. So they're still okay in that range of the numbers. We should really be looking to delay the onset of myopia. Kids grow and they're going to grow. So we want to make sure that we delay it as myopia as long as we possibly can. The number one way you can do that is get them outside. Let's get these kids outside. And it has to do with, the brightness of light and inside it just doesn't cut it. So even a cloudy day is actually better to be outside than inside. So outdoor time is super, super duper important. Also, keeping these kids at less than 2 hours per day of near work. And that's besides school time. So school time, that's something we're not able to control. Also in school, they're looking up and down. But the studies tell us less than 2 hours per day of near work is something that is really going to help. Also frequent breaks from near work. Every 30 minutes, they should be taking a 5-minute break. And the reason for that is it actually relaxes the choroid and allows it to kind of get back to normal. That 5-minute break should actually be in a open environment. So actually get up from the reading that you're doing, or if you're playing a game or something, you need to actually get up, go outside. I tell them to take a walk the dog, go get the mail. Some kind of open environment is really ideal. And then we talk about working distance. So increasing the working distance and making sure that they're not reading too close. Um, if the kids actually have a refractive status that's less than expected, or they have a lot of risk factors, then you should intervene actually as soon as possible, either with like low dose atropine, or anti-myopia glasses. Now, we don't have the anti-myopia glasses in the US just yet. It's coming, but it's not here just yet. But you at least need to tell them about the lifestyle modifications. It's extremely important, and it's something that you can incorporate and change their habits, their daily habits, to really benefit them in the long run. As we said, modifiable risk factors are outdoor time and the near tasks. The odds of myopia is increased by 2% for every 1 diopter hour of near work per week. That is amazing to me, honestly. So we really need to concentrate on this. All of our kids really should be doing this. This is something that is very very doable, and it gets our kids outside, away from screens, away from things that are up close. We know that outdoor time does delay the onset of myopia, but there is also some benefit in slowing down the progression of myopia. Another thing I just wanted to mention is that also there is a seasonal change in axial length. So for those of you out there who measure axial length, you might notice when it's wintertime and there's very little sun time, or very little time that it's light outside, you may see a little bit of an increase in the axial length of your kids. But then, I'm sorry, an increase in the axial length of the kids. But then later on, it actually goes down again. So there is a little bit of a seasonal variation there. Okay. Talking about other near work modifications, I will demonstrate to the kids, and I'll tell them about the harm and distance. We all learned about that, right? Um, but I tell them they should be an elbow away, and that actually is something that they remember because I put my arm in an L. And I said, this is an elbow, so your arm should be in an L. That's the closest that you should be with anything. Um, and then if I bring it too close, I say, this is a V. We don't want a V bow, we want an elbow. I actually got that from a friend of mine, Dr. Carrie Alfieri. But they actually remember that. They giggle and they laugh and they do remember that. So that's actually a nice little reminder for the kids. It's very interesting that a close working distance is actually an independent risk factor for myopia, as well as increased smartphone use. So, delay the kids from getting a smartphone as much as possible. There are phones out there that are just phones. So they don't have to use it for other things. There is such a thing out there. So definitely encourage that. I do go through in my exam and I'll tell them, like this. So the worst thing is a smartphone because it's usually very small. They bring it up very close to their face. And you'll even see them in the waiting room and everything, they're just sitting there on their phones. So we talk about elbow distance, and then I tell them if they have a laptop computer, which a lot of the schools actually do have a laptop, that should be at palm distance. So I have them put out their hand and just kind of demonstrate like, oh, that's the closest your laptop should be to you. And then fingertips for the monitor. And then I have a lot of gamers, and you might have a lot of gamers in your office too. But I actually tell them if they can take their handheld games um, and dock it, and then have it projected on a screen across the room, like on a TV or something across the room. Some of them actually have never even thought about that. But if they possibly can, I tell them, the further away, the better. And that has actually really helped a lot of my patients and solved a lot of things, especially for my gaming community. Um, the other thing we talk about is good light. Good light is super important. Near tasks in dim light are also a risk factor for myopia. So when your mom or your grandmom said, "Oh, don't read in dim light," they were right. So yeah, we definitely need to make sure that you have good ambient light in the room when you're working on any kind of near projects. Take those breaks, like I said, 5 minutes after 30 minutes, doing something completely different. The 20-20-20 rule is not enough for myopia. It's great for dry eye, but it doesn't actually give enough time. 20 seconds is not enough time for the retina to actually recover from all of that near work. So just be aware of that. Let's talk a little bit about treatments. So we have low dose atropine, which I'm sure you've all heard about. Low dose atropine obviously is pharmacologic. It works on the retina. And there are a lot of studies going on right now about atropine. LAMP has a phase 4 study, which actually recommended that 0.05% is actually the best percentage for treatment for axial length and for refractive error. And also the Mosaic 2 study was another study that was released that also said 0.05% is actually the best place to start. As a note, atropine is not yet approved in the United States. And there's a big variation in different pharmacies, compounding pharmacies. So you don't always know exactly what you get if you go to different pharmacies. So there are a few companies who are going through trials on low-dose atropine, and hopefully we will have an FDA-approved low-dose atropine product in the next year or two, possibly. So the other thing, so everyone knows about optical treatments, right? So we have the myopia control soft contact lenses, CooperVision's MiSight 1-Day. It's a dual focus lens, 1-day disposable lens, super comfortable, super easy to handle. And CooperVision actually has the longest clinical trials of any company out there. Um, they have a 7-year, last year they released their 7-year study, which is a prospective, multi-center, randomized study, they're getting more than 50% control of the myopia with no rebound on discontinuation. So that is really, really huge. And this is a fantastic, fantastic lens and design. So I definitely, I definitely recommend that as a modality to present to your patients. The other soft lens that actually is undergoing trials right now, they've completed 1 year, is the VTI Natural View Multifocal. They have 1-year studies out that look very good. It's not yet FDA approved. They're in a 3-year study at this point in time. Let's talk a little bit about Ortho-K. So Ortho-K was actually originally approved for overnight wear in 2002. And in 2021, the FDA approved the J&J Ability Ortho-K for myopia management. The thing with Ortho-K is you really have to, you need a topographer. You have to be very vested in fitting, making adjustments, looking at your topographies, comparing your topographies. And also, you really do need an axial length measurement, an optical myometer. That's really the best way to tell with orthokeratology if the length of the eye is changing. It's not a refractive type of a change that you can tell with Ortho-K. Just as a note with the MiSight and the natural view lens, it's very easy. So the entry into those into those lenses, especially the MiSight lens, is very easy. We all know how to fit a contact lens, right? We all know how to do a refraction. And you just need to, watch the child and see if things are changing, talk to them about lifestyle. And it is very, we have everything we need to fit a child with a MiSight lens, for example. Combination treatments are out there. We do use them for our fast progressors. And it would be low-dose atropine with a soft myopia control lens or multifocal, or with Ortho-K. So there are a number of studies that are going on about what's the proper dosage, what's the proper amount for how much time to do a combination study. or I'm sorry, to do a combination for the child. And they are ongoing. That's an ongoing thing, but it does, there is a benefit. There's definitely a benefit there for the fast progressors. All right, other treatments. I'm not going to spend too much time on this because we don't have these treatments in the US. Spectacle lenses. I'm sure you've all heard about this. Our Canadian neighbors up north do have the spectacle lenses. Right now, the most effective and the most studies are done uh, with the DIMS, the HALT, and the DOT lenses. And other designs are being studied, but we really don't have good really don't have good results for them just yet. You can actually use a glasses lens, anti-myopia lens for a pre-myope also. And I do have to say, I do have actually patients in the MySite in a very, very low or a plano prescription, just for myopia control. So that's another thing for pre-myopes that you can do. You'll hear a lot about light therapy. There's different kinds of light therapy out there. There's bright light therapy. There's the repeated low level red light therapy. There's the blue light therapy. You'll hear about violet light. So all of those things are really needed there's a lot of information that still needs to be collected about those, and studies need to be done. Um, and that's all I'm going to say about that because it's really very new. There is an oral drop of a caffeine derivative drop that's being used in Denmark that is showing some promise in initial studies, but more studies need to be done about that. All right, let's get into the good stuff. So our treatment considerations, we really need to consider a few things with what treatments we go with here. One is quality of vision. So we all know that contact lenses actually give better quality of vision because of peripheral vision, and kids' glasses get very dirty, things like that. So the quality of vision is slightly better for soft lenses or ortho-K, where you actually don't wear any lenses or anything at all during the day. Quality of life is definitely higher for ortho-K and soft myopia control lenses. And compliance to these things, to these treatments, is influenced by motivation, comfort, vision, lifestyle. So you have to kind of consider the child and consider the parent and the family and what's going on in the family dynamic. Some very chaotic, hectic households will not do well with ortho-K. So, you just have to kind of consider that if they're not going to be compliant, then your treatment is not going to be very effective. So it makes sense. Safety. We know that soft contact lenses and ortho-K have very rare adverse events, very rare. And the safest age group are actually 8 to 12 years old. And that's even compared to teens and adults. The 8 to 12-year-olds are actually, they're in learning mode. They're already, they pay attention and they listen to directions. And they are actually excellent contact lens and ortho-K wearers. So the benefits of any types of myopia control far outweigh the risks for sure. Sorry about that. Okay, so our treatment advantages, there's advantages and disadvantages to each of them, and parents will ask me about that. Um, Ortho-K and soft multifocal contact lenses definitely give them the freedom. Um, freedom from glasses, and they definitely have a better self-esteem. There are there are definitely studies out there that show that there is a difference in the confidence level of these children, and it definitely makes their activities and their sports more enjoyable, less cumbersome, especially if they have helmets on, or they have goggles that they have to wear, or cages, or whatever. It's definitely more comfortable for them with a contact lens, or doing ortho-K, because they don't have anything at all in their face. If a patient is a swimmer, we have a lot of competitive swimmers in our practice. Ortho-K is definitely the way to go, because you can't swim with contact lenses in. And they spend a lot of hours in the pool. So Ortho-K is definitely the way to go with the swimmers, for sure. The kids really, they really get a good sense of themselves. They know that they're like helping themselves out. Um, they actually have a better hygiene when they are in contact lenses. They know that they need to keep their face clean, keep their hands clean, and everything. They also know that they need to kind of balance things out as far as um, how much sleep they're going to get, how long they wear their lenses, their outside time, things like that. So it's kind of a very interesting thing that kids who wear contact lenses and ortho-K, they kind of have a better sense of self. Um, we need to be very positive with these kids, and encourage our children to um, really be confident in themselves, and help them along. Kids do hard things. So my good friend Justin Kwan, colleague, he always says, kids do hard things, and they really do. They really do. Um, and they can do this. They can definitely do this. And if you give them the tools, and you give them the instructions, they will definitely be able to do this. Don't think that a kid is too young to do this. They definitely can. So why is this so important? Well, we talked about this, the stabilization of their prescription of their axial length is really going to help them in the long run, decreasing their risk for maculopathy, retinal detachments, cataracts, glaucoma, all of that. Um, and also, parents will say like, "Oh, I just want to get them refractive surgery." Well, they'll actually have better options for refractive surgery if their prescription is lower, and the outcomes are going to be better with the refractive surgery if their prescription is lower. So, so really, the time to act with this is now. It's not, let's wait and see. Like I said before, the earlier the kids get into some kind of treatment, the better, because younger kids progress faster. We know that. Kids are not too young to start, and they're not too old to start either. About 50% of 20-year-olds actually will continue to progress into their mid 20s, and about 20 through their late 20s. We've even had, you heard about college myopia. There is, the soft contact lenses are fantastic. Like the MySight lenses are fantastic for treating college, what we call college myopia, because they just have so much near work, especially if they're going to grad school. It really, really helps. Talking to our parents and patients about myopia. I love this, and this is actually my favorite part of the practice. You just have to kind of come to their level. Explain what myopia is, explain what the problem is. be positive. It's kind of like this is bad news. Bad news is, you're myopic and it's going to get worse. The good news is we now have great treatments that we can help you, and reinforce your findings with graphs and charts and videos and things so that they really have a good handle on this. Many people are visual learners, and they will really take to this and just make sure you're simplifying it enough for them, um, and give them a summary. Tell them like what their vision is, what their axial length is, what those lifestyle tips are. Um, Many of our manufacturers, they actually, our industry partners, they actually have tools and resources that can help you with that. Um, and parents really do appreciate this. They really appreciate it. The other thing is that educate your team, have a myopia coordinator, have someone who will actually help you with that education, because you won't be able to do 100% of it. And they're extremely important. Your team is extremely important. And I know that our industry partners are more than happy to come into the office, do a lunch and learn, and teach your staff about myopia and what we can do and what the different treatments are. So definitely utilize them. Um, the other thing about talking with parents, we have a lot of parents who are non-English speaking. I've oftentimes gotten onto Google Translate, and that's how we're communicating. But sometimes they actually don't like to talk. They would rather text or email you with issues. You just have to find out what is really going to be the best thing for them. Be open to whatever might be easiest for them, whether it be a phone call, a video call. If they want to come in person, we have to kind of break down those barriers to communication, and take a soft approach to communicating with our parents and with our patients. Um, the other thing is, there are really nice websites. Like CooperVision has a fantastic website that will explain about not only their MySight lens, but just myopia in general. And so direct the parents to there instead of just saying like Google it. um, it's really great to see that our manufacturers will have so much great information, and it's general information. Yes, they have it about their specific products, but it's also very good general information too. Um, on the follow-ups, I always speak with the parents, or write them a little note or a little text, and tell them like, how is your kid doing? How's the vision? How's their axial length? How are the lifestyle modifications going? And just kind of give them a little bit of report, and they feel a lot better about bringing their child to you, that you're actually paying attention to them. And then they actually have some feedback, because oftentimes the parents won't get feedback from the kids. So they're actually looking to you to know, is this working? Is this extra time and everything, worth it for me? And always pre-appoint, them. Okay. So we talked a little bit about this. Safety is super important. You have to let the parents know, even if they don't really ask too much about it. The safety of the lenses, and the treatments that you're doing, are very safe. Um, they're also very effective. We have lots of studies going on. And like I said, CooperVision has the MySight is the longest continuous soft contact lens study for myopia control of anything out there. So that's actually fantastic. Um, You do also have to disclose to your parents some things are off label and some things are non-FDA approved. So you could go off label with parameters, say, for instance, of ortho-K, if they're more than 1.5 diopters of astigmatism, that's considered off label. If you use a ortho-K material that is not FDA approved, that's actually off label. Not that we won't do it or we can't do it. It's just you have to realize that there aren't studies that have been done on that. And FDA atropine is not FDA approved just yet, so they need to be aware of that. Um, and parents always ask me, what is the best thing? What is the best treatment for my child? The best treatment is the one that your child will do. So, you could sit there and talk to your blue in the face about soft contact lenses and how great they are and how safe they are. You turn to the kid and the kid's like, I'm not touching my eyes. That's not going to work. So, so yeah, I mean, if the kid's not going to do it, then that's something that you have to consider. What is going to be the best is what they're going to actually be open to do. Um, Expectations. Kids will take a little bit extra time. Like we said before, kids do hard things. They will learn. It only takes a few minutes more for a child, a preteen or elementary school child to learn to insert and remove a contact lens than teenagers. Adults forget it, they're uh, they're harder actually. Um, but just be patient with the child. I actually liken it to if they're learning an instrument. I asked the kid, do you know how to hold, like, say they're playing the violin for the first time. I said, did you know how to hold the violin? Do you know where to put your hands? Do you know what to do? And they're like, no. And I'm like, well, it's the same thing with a contact lens. So you'll learn it. We'll teach you. You'll learn it. You have to practice, and you'll get it. So they really like that, and it's a very, very realistic type of training that they go through, and they understand that they understand it. Then it's not an instant thing. Um, so the other thing is, you have to expect with soft contact lenses, they have to open their eyes up much wider than ortho K. They need to wear the soft lenses minimums is 6 days a week for 10 hours a day. They can take a day off, but honestly, most of my kids, they'll wear them 7 days a week for like 13, 14 hours a day. They're super comfortable. Ortho K, higher prescriptions, especially, you have to just make them aware that it's going to take a little bit of time and they may need a bridge of a soft lens. So that could happen. And they definitely need very specific solutions, preservative-free solutions for their Ortho K to avoid any problems. Also with expectations, it's very important for the parents to realize that follow-ups are extremely important. And then if there are any issues that come up, they need to contact us right away. Don't go to your pediatrician who knows absolutely nothing about, contact lenses or ortho-K, for them to, prescribe something that's inappropriate. Just come to us because it might be a very simple answer. So, make sure that you are in touch with us. There's different levels of commitment. The first year are more appointments. As the years go on, and the stability is there, then we actually have less appointments, but you need to actually get your child there. Give the child a little extra time for insertion removal. They should still have their yearly dilated exams, and there's going to be a program renewal. It might be a year or 2 years, whatever you decide in your office is fine. We as doctors have to be committed and realize that we need to be available for these patients. They are paying for a premium service. Um, and we just need to be available for them and give them the time in our schedule, and also to address their questions. Um, and also, like I said before, with the with our team really, really needs to be educated on myopia. Um, and that is a commitment from us, coming from us as doctors, and bringing in someone to help to educate our team, or there are other resources out there. If you're interested, I mean, there's a few other there are a few resources to actually train your team that are extremely, extremely helpful. So, kind of wrapping things up here, um, you need to know how to identify these patients. Um, who's a good candidate? Who's going to progress? Why the progression is bad? And, just to definitely convey to your parents who actually can, what is going to help this child is going to help them in the long run also. So it's not just a short-term thing, it's um, a long-term thing. Every kid is different, and they need different treatments, and not everything works for every single child. Leave time for your parents and for your patients. Um, Make sure you explain the process of what's going on. Um, and it definitely will lead to your commitment will lead to um, increases in your conversion rates, your retention rates, your referrals. People will refer to you and say, they took great care of my child, and I know they're going to take great care of you. Um, but we need all of you. I'm a specialist, and this is the only thing that I do. There are very, very, very few of me, but there are a lot of kids out there who need our help. And we need each one of you to actually help us to identify these kids. And if you actually don't do myopia management in your office, at least you can identify these children and refer them to someone who does. Um, and we co-manage in our office all the time. Um, but we want you to be the primary doctor, the one who actually brings us to their attention, um, and you will be able to benefit these children for the rest of their life. So this is a long-term solution to something that has been around for a long time, and we really need to help our kids out, because really our children are our future. Um, and the numbers, the statistics are really staggering.